Good morning, everyone. I know I'm the last one standing between this and lunch, so let's keep it quick. Thank you, Dr. Sharma, Dr. Kinney, Beth, and Tom for the invitation. And I've been assigned to talk on latest advancements in mitral and tricuspid transcatheter interventions, and I have no conflicts related to this talk. I'm going to start with tricuspid because we all know, we keep saying that it's the most forgotten valve, but the landscape in the tricuspid valve interventions, especially related to transcatheter interventions, has been exploding in the last 1 year with a lot of data and FDA approval of some exciting therapies that we can offer to our patients. So tricuspid regurg, as you can imagine, is highly prevalent, and it actually is more prevalent as patients get older. And guess what? It's approximately even 1/4 of all left-sided valve disease, similar to even prevalence of aortic stenosis. And not having tricuspid regurg fixed is not good, because you can see that having tricuspid regurg, even moderate or more compared to trivial, is associated with high mortality. And when you actually stratify it according to the severity scale, of course, patients with moderate or severe tricuspid regurg, they tend to live shorter and with bad quality of life compared to patients with mild or less than mild tricuspid regurg. What are the challenges that we have while we take care of these patients? First of all, it's highly prevalent, but still, unfortunately, these patients are not getting the right therapy. Only 0.4% of patients are being surgically treated today. And it's a severe undertreatment, and the prevalence is almost similar to aortic stenosis. And unfortunately, the medical therapy options that we have for these patients are also limited, because by the time these patients come to us or refer to us for management of TR, they already had at least one or even two open heart surgeries, and they've had multiple procedures. They probably come to us after they've been taken care of by multiple providers, and unfortunately, those treatment options didn't work. So we are seeing the sickest of sickest patients when we see these patients. What are the clinical manifestations? Usually decreased quality of life, exertional shortness of breath, not able to do things. Those are subtle starting signs, and the more worse would be like recurrent heart failure hospitalizations. And if you examine these patients, you're going to see a tall JVD going all the way up to the neck, and classic right heart failure symptoms, which is swelling in the legs and swelling in the abdomen from hepatomegaly. And it's a class 2A indication now for medical management. Even in the guidelines, we are not there yet for the class 1. It's only a class 2A indication for symptoms of right-sided heart failure with medical management. And if you look at the patients, all these patients is a class 1 indication to get a transthoracic echocardiogram. The transthoracic echocardiogram is help you identify the severity, because the echocardiogram is done in a more physiological state where patients are walking, awake, and talking to us. Rather, the transesophageal echocardiogram, which is the one that we do like an endoscopy going down the throat, is going to help us understand the etiology, why this patient has TR, where is the TR, and what can we do can we offer them any therapies for that. And the etiology, if you look into it, primarily the tricuspid valve is not the culprit. 95% of the time, it's secondary, meaning it's either a left-sided pathology or because of severe lung issues or because the RV is dilated or the RA is dilated. So the valve themselves are opening and closing fine, but they're just being pulled apart or being tethered, like meaning pulled down, so they're not making a seal. So the valve themselves are okay. Very rarely we do see primary TR, where the valve themselves are a problem, where the valve is flip-flopping. And the most common ones are either because of infective endocarditis, or you actually have a pacemaker lead or an ICD lead that's going and tethering the leaflets. The tricuspid valve anatomy is a little complex. You can see in the structure, it's closer to the conduction system of the heart. And also, this is actually a three-dimensional structure. Unlike mitral or aortic, when you plan to do any intervention, you need to actually have advanced imaging so that you can see all the three leaflets in one setting, because otherwise you're going to see only two of them. Tricuspid is three. So that complicates a little bit to begin with. And if you look at the anatomy and the way that the physiology expands or explains when there's severe TR, there's going to be expansion of the right atrium up top or the expansion of the right ventricle from down below, which actually dilates the annulus and pulls the leaflets and also pulls them down. Or the septum, which we commonly see on the echocardiogram, becomes flat and gets pushed to the left, which is usually opposite because the left side is a high systemic, high pressure system. So the septum bows to the right in normal cases, but in patients with TR, the pressure inside the right side is so high that the septum is actually pushing towards the left side. And if you look at the guidelines for intervention, the guidelines say it's actually a class 1B indication if the patient's actually going for surgery. But other than that, for secondary TR, only if the patients are failed medical management, it's actually appropriate to treat these patients. And that's from the ACC-AHA. From the ESC, they're a little bit more aggressive, and they give a class 1 indication if the patients are going for other surgeries and the patient has at least moderate or more than moderate TR, and at the same time actually have symptomatic severe TR despite medical therapy. And this is a busy slide, but basically what it's telling you is if you need a combination of both transthoracic and esophageal echocardiogram to help us understand, number one, whether this patient actually has severe TR or moderate to severe TR, and number two, what is the mechanism or the reason why this patient has severe TR, and is this something that we can actually approach or is feasible for surgical or transcatheter interventions. So all our patients start with a transthoracic echo, then we guideline direct them with a medical therapy, and then repeat another transthoracic echo. If the repeat transthoracic echo shows that they have severe TR despite medical therapy, only then we pursue transesophageal echo. We don't do transesophageal echo on all comers because you never know. You put them on medical therapy and the TR might actually get better. Now, there's a different, another challenge with TR is the definition and nomenclature keeps changing day by day. But the most standard one that we've been using so far when we see these patients is actually on a 5-scale severity of TR. The more relevant ones are severe, massive, and torrential, which tells you that if you see severe TR, you're not that bad. You're in the middle of the spectrum. You can have torrential TR. So if you put a number, if you have a number grade to this, it's 1, 2, 3, 4, 5. And sometimes we even say the patient has 7+ TR, so more than torrential. So you can see extremes of severity of TR. And we have a wide landscape of options that we can offer these patients, which means it's good and bad. The bad thing is like nothing is being proven to be the best effective option so far until like we have, we want to see in the next few slides what happened in the last 1 year. But the good thing is like there's a lot of research going on and a lot of options. And say, for example, if patients have a surgery for an isolated tricuspid valve issue, the mortality in hospital is 8.8%. So it goes to tell you that surgical intervention of tricuspid is actually not benign. People might think it's a right side valve and it should be okay, patients tolerate it, but the in-hospital mortality is pretty remarkable at 8.8%, which goes to tell you that these patients are super sick, and hence we need to be very careful, not just doing the procedure, but pre-habbing them and post-habbing them before and after procedures. It could be either surgical or transcatheter intervention. So now let's pay attention to the transcatheter landscape. So the two big things that hit the whole structural hearts field in the last 1 year is actually the tricuspid clip, which is the edge-to-edge repair, and the other one is the tricuspid valve replacement. Completely the valve gets replaced, which is called the EVOQUE. These approvals came because of these landmark trials. The TriLuminate trial was the pivotal trial. There's actually a graphic of how the system looks like, the TriClip, but now we have moved on to the newer generation. It's called G5. This is a G4, and we are one of the few hospitals in the country to test the pre-hospital, pre-market evaluation. And these patients were randomized in the TriLuminate trial, 1-on-1 to TriClip versus medical therapy, and the primary endpoint is a composite of mortality, any other tricuspid surgery, heart failure hospitalization, and clinically, subjectively how the patient feels, which is assessed by the KCC cancer score. And you can see there's a significant reduction in the device arm at 30 days, and compared to the medical arm, 87% of the patients were already downgraded to moderate or less than moderate TR. And if you look at the paired analysis, the effect remains still until 1 year. And most importantly, when you actually do this complex statistics, they also look at a win ratio, meaning like you win if you actually have a number that's more than 1, where all the outcomes are pooled together. And you can see that the win ratio was slightly above 1 with a 1.48 and a significant p-value. And the most important thing that we ask our patients after any procedure or any intervention, any medical therapies, how do they feel? So after the TriClip, you can see in the right side of the chart where the KCCQ change more than 50 points was tremendous with a significant p-value. But there was no significant difference between the death or valve surgery or heart failure hospitalization. And this is actually just splitting into the win ratios, and most of the win ratios was towards the KCCQ score. And the other edge-to-edge repair device that we have is called the Pascal. The Pascal is, so when we have TR, we talked about how primary and secondary TR is. So the Pascal is mainly for primary TR. It's not a clip, but it's an edge-to-edge repair device. It's not a replacement, it's a repair. And it actually is a little different than the clip because it doesn't pull the annulus together, and it actually has elongators and spacers. So the leaflets rest on the clasp, the elongators and the spacers, and then we close them. And the data comes from the CLASP TR study, which is just single arm prospective trial, and it showed that, again, it helped improve the quality of life in these patients. The CLASP 2 is going on now, which is similar to the TriLuminate, where they're randomizing patients on medical therapy versus medical therapy and Pascal. So that's repair, and now going on to the replacement, the first one that got approved by the FDA last year was Evoke. And there are other bunch of devices too, but Evoke is like similar to a TAVR. It's a complete valve replacement of the tricuspid valve. It's procedurally relatively easier unless you have great imaging. And the diagram, the graphic actually shows you how you cross the valve, you go into the right ventricle, you go underneath the leaflets, and you expose the valve, you expose the anchors, and slowly pull up. And the right side actually shows how the echocardiogram looks like when you deploy the valve, so that you actually have gotten all the leaflets hanging on to the anchors. And the data comes from TRISCEND study, and the TRISCEND study did show that there's a significant improvement in the NYHA class, and functionally and subjectively the patient feels much better. And then there were 400 patients who were randomized, and they did not still show any difference between hard clinical outcomes. The one thing we need to remember when you're putting a big device like a valve on the right side is the risk of pacemakers, because they're very close to the conduction system. So you can see that there's a significant increase in the risk of pacemaker after this procedure. And also these patients need to go on blood thinners like anticoagulants, because right side is a low flow state, and we're going to put in a big device, it can create a nidus for thrombus. These are the pros and cons of repair versus replacement. And the win ratio was also significant. And the win ratio here was actually slightly higher if you want to compare with the TriLuminate folks. So for patients with severe TR, TTVR was superior to medical therapy alone for primary composite outcome, driven mainly by subjective symptoms and quality of life, which is still important. And the other valve replacements is Interpret, which is still a work in progress. Just for the sake of time, just moving along. It's actually a little more complex procedure where you can actually look at this. It's a big device. It's a 35-French system. It goes in, so it's the early feasibility study is actually going on right now, and hopefully we'll be enrolling patients for the tricuspid space. We have trials here for the mitral space, so the tricuspid will be next. And one such other thing is actually the self-expanding valves that we put in the IVC and SVC. It's just a palliative procedure. It's called trick valve. You're not doing anything to the tricuspid valve. Rather, you're actually putting two valves on the SVC and the IVC, and that's kind of like limiting the blood going in and smoothing so that there's actually less pressure changes in the right side of the heart, and patients feel better. So it's more of a palliative procedure, and it is also in trial stage. So this is the landscape. So there's so many devices, but there's two different devices that we went through, which is the TriClip and the TTVR, and the FDA approval came in February and April of 2024. So I would say still it's exciting time for the transcatheter tricuspid space. At Sinai, we have tremendously improved our volume. You can see we have done 43 tricuspid clips and 16 evokes in the last year. And not only that, our metrics is much better. We do it faster, efficient, and we tend to actually use there are 4 clips that comes with it. XTW is actually the wider, big clip, and that's what we use more often. So that's tricuspid. And now I have 5 more minutes. Mitral, most of us know because I think it's actually an evolving field, but it's not new anymore, and we have a lot of good data, and so we'll be quick with that. So, but still, there's a lot of patients who are not treated. Can you imagine, like in 49% of patients who have primary MR, which is a class 1 indication to get surgery, they're not getting surgery just because they're a high risk. And you can see on the circle diagram over there that if you don't treat the MR, it actually goes in a vicious cycle, and the LV gets dilated, and your mortality is almost like 57%. So every other patient is almost going to die if they don't get treated with CVMR. Similar to tricuspid, there's 2 classifications where the problem is in the valve themselves, that's a primary MR, or secondary MR where the problem is not in the valve, but it's in the chamber or in the subvalvular apparatus. It could be the dilatation of left ventricle or the left atrium. And it goes to say that if you have a primary MR, unless the patient is prohibitive risk for surgery, they should go for surgery. If not, they can come for transcatheter intervention. For secondary MR, it's a team approach where you actually have medical management with the heart failure doctors, and if the patient have AFib, you also need to see the electrophysiologist to see if there's any benefit in putting them back into sinus rhythm. And we use the same transthoracic echo to assess the severity, transesophageal echo to assess the etiology, like why there's an MR. Most of the times when you're seeing these patients, don't be surprised if on the TEE, if the MR or TR is not severe, you shouldn't be surprised. Why? Because we knock these patients out, their blood pressure is subphysiological. Of course, their MR or TR, which is a dynamic response, is going to be less. So never go with the severity of a valvular lesion on a transesophageal echo because the dynamics are non-physiological, meaning they're sleeping. They're not walking and doing things at that time. We talked about it, surgery, and with secondary MR is transcatheter repair. So I'm going to quickly go through a case where this is a patient where we actually had wide open MR. You can see there's the LV and LA both are dilated. And we did 2 clips here. And when we do the clips, you can see the orientation of the clips here with this actually the 2 red markers. These are the clips look like. We actually have a game plan ahead of time before we go in, and so that we are we have a good plan for any surprise. So we did the 2 clips, and this is actually after the clips. You can see that there's a significant reduction in MR, and you also see that not only by color Doppler, but by physiology as well, there's improvement in hemodynamics. So you look at the pulmonary veins. When there's severe MR, the blood gets backed up into the pulmonary veins. So you see a reversal of flow here. And over here, you can actually see everything is up, which is normalized. So this means that you have done a meaningful physiological reduction in MR. These can be obtained by the intraprocedural transesophageal echo. And these are 3D, where you can actually see this is before and this is after. You can actually see like an owl's eye. We call it Alfieri stitch, where you actually have the owl's eye. That means you actually almost got like a surgery-like results. And this is actually where you see the hemodynamics, where the LA pressures. Sometimes your LA pressures don't come down as impressive as the color Doppler went down, as impressive as your veins improved, because the left atrium is probably already remodeled, and even if you decrease the leak, it's going to take some time for the left atrial pressure or the left atrium to kind of like shrink back in size. So just going by the LA pressure alone may not be a helpful marker to help us identify whether we did a good job or not. And looking at the 3 trials, we have 90 seconds. So looking at the 3 trials, COAPT, MITRA FR, and Reshape Heart Failure 2. So we all know COAPT. Dr. Stone actually was a principal investigator. That's for all functional MRs. MITRA FR is a European trial. That's also for functional MRs, but the LV size was big, meaning they didn't have cutoffs for patients who came in with LV size. And Reshape Heart Failure 2 was the most recent trial, which was actually published in the ESC last year. And it was actually a very informative and very interesting trial, which published in New England Journal of Medicine. So they randomized 200 patients, 250 patients in two groups, which is mitral clip alone and then versus guideline-directed medical therapy. And what they found was actually, this is a primary endpoints. What they found is you can see a significant reduction in heart failure, recurrent heart failure hospitalization, or cardiovascular death, recurrent heart failure hospitalization alone in 24 months, and improvement in KCC score. So basically, this effect on the subgroup was even better if the patients were hospitalized in the last 12 months due to heart failure. Meaning if you selectively handpick your patients who are actually tend to be more beneficial for this procedure is wonderful. That's exactly what the Reshape Heart Failure 2 trial showed us. And this is actually a comparison. This editorial was written by Bob and one of our fellows and Dr. Stone. It's actually comparing all the three trials over here. One more thing to note is this is actually looking at the severity of the MR. So in the COAP trial, which was in the US, everyone actually had definite severe MR. In the Mitral FR and the Reshape, it was moderate to severe MR. But what Reshape taught us is even if you have moderate to severe MR, the MR doesn't have to be severe, but you choose your patients and they're optimally managed by medical therapy, and your LV is not so dilated, and especially if those patients were hospitalized recently, you have benefit of doing this procedure. So that's what we learned. I want to stress on this one here. So if you look at this, medical therapy is very important. Let me go back, sorry. Yeah, so you can see here in the COAPT and Reshape Heart Failure 2, optimally managed medical therapy. So it doesn't matter whatever we do or offer therapy, medical therapy goes a long way. And in the Mitral FR, it was just like community management, like meaning more real world management, but we need to be optimally managed. So that's another important take-home message. So these are our mitral clip volume. In the last year, we did 96 mitral clips, including 5 Pascals. And again, if we are very efficient, we do faster, we have a rigorous protocol. So take-home message is tricuspid regurg worsen survival and quality of life with limited options, especially surgery, because super high postoperative mortality. And the transcatheter therapies, including repair and replacement, is good, less invasive, effective options. It improves quality of life and symptoms. And mitral TEER is an established option for degenerative and functional MR, especially with the Reshape Heart Failure trial last year, supporting that even in moderate to severe MR, hand-picked patients, especially if they are being hospitalized in the last year with heart failure, it works great. And now we have to see what the other trial is going to show and what are the other devices going to show. Thank you so much for your time.